Sure. Okay, I think we should be going. Good evening, everybody. Welcome to our March webinar. I've just got a few quick announcements before we get going here. I'm going to share my screen real quick. And okay, great. Okay, so just a few quick announcements before we get started. I'm going to go over a few links. They're all going to be available in the chat. So if you're looking for a link, Darla is putting them in the chat. During the Q&A portion of tonight's talk, please type your questions into the Q&A feature of Zoom. If you put your questions in chat, we're not going to see them. So put them in the Q&A feature of Zoom. And Darla is here. Darla, our patient affairs director, is in the chat. She's going to be providing tech support. She'll be putting links in there, and then she'll be helping me moderate the Q&A at the end of the talk. Just a few other quick announcements. So we have our CCM support group tonight at 8 p.m. Eastern Time. The Zoom link will be in the chat. We have a lot of upcoming events at the Alliance to Cure. We've got golf tournaments. We got Strides to Cure in June. We have a family camp coming up in July. So I just wanted to give a quick shout out. So we have CCM Family Weekend. It'll be July 17th to 20th at Ironwood Springs Ranch near Rochester, Minnesota, and registration is open. So please check out that link to register. We'd love to see you there. Okay, and I just wanted to welcome our speaker tonight. So, welcome to Dr. Ed Smith. He is a pediatric neurosurgeon and medical director at the CCM Center of Excellence at Boston Children's Hospital. He's also the vice chair of the Department of Neurosurgery. He's the co-director of the Cerebrovascular Surgery and Intervention Center. He's a professor at Harvard Medical School, and then he's also the chair of the Alliance to Cure Medical Advisory Board. We're just so lucky to have Dr. Smith in the CCM space. Like he's really a real champion for excellent CCM care for the CCM Centers program. Just so thrilled to have you here. You're just a real, really wonderful person to have in the community and clinician. So thank you so much. And I'll turn things over to you to get started.
Well, I'll have to give you your 20 bucks for the kind introduction after. So thank you very much. And to everybody out there, thank you. This is meant to be a little bit of a discussion. I'll pop my slides up in just a second. But, in talking at the meeting recently, it sort of came up that a number of people, we talk a lot about research, but I think that it's not always clear. People throw around these words, IRBs and phase ones and, phaser beams and goodness knows what else. So I've sort of got this talk into three parts. The first is just a general overview to hopefully demystify some of the spy talk that us clinician people and science people use, and I don't even know all the words all the time. So hopefully this demystifies and brings everybody to the same sort of vocabulary. The next part is talk a little bit about some advances in research in surgery, since I'm a surgeon, and that's important and near and dear to my heart, along with the patients we treat. And then finally, to wrap up with a little bit of some translational research, just in particular things that are going on at Boston Children's and Harvard. Obviously, this can't cover all of research. We'd be here for weeks, and it's super exciting. And I really want to compliment the Alliance for all the incredible support they give to research, which I think is part of the reason we've been able to do so much better with everything we've been doing. So that's the framework. I'm going to talk for about 8 to 10 hours. I hope it'll wrap up pretty quickly. But again, this is meant to be more of a discussion than a lecture. So please jump in, and we will try to answer questions at the end. This is always the scariest part of any talk for me, is to make sure that you can see my magic Zoom stuff. So, Kate, maybe you can tell me, can you see magic Zoom stuff up there?
We can see
Good.
it. We can
All
see the
right.
magic.
So, well, yeah, it's debatable, but it might sound silly, but I'd like to start with the idea, why do we do research? People talk about all the time, everybody's running a 5K to cure something. I think probably from the beginning, it's important to frame out why the heck we do research. And, the short answer is it helps us to understand diseases that affect people we care about, people that we are all part of, presumably because of this group. And as it's designed to improve care. As good as things might be, they can always be better. My wife says that a lot about our marriage after 30 years, but we keep working at it. So part of that, just like a marriage, is that there really needs to be partnership in research. And I think one of the great things about the alliance is the very first word of alliance is alliance. It is bringing together people that have different viewpoints. You need scientists to be able to do the scientific work. You need clinicians or doctors, and not all doctors are clinicians, not all clinicians are doctors, but people that are engaged in the, bedside care, the office care of people with disease and things that need to be made better. And really important, and I think one of the great strengths of this particular group is the engagement of the patients and families themselves. Far too often, at least what I see sometimes, is that research is going off on a tangent and it's being driven by, the nerds in the lab or the arrogant doctors, and you're really not getting the input of the families and the patients who they're the ones that frankly should tell us where the focus should be. And so that's where I think this particular alliance is so, so great. Um, for the coalition itself, I think one of the great things about this group is that, as I mentioned, it breaks down the silos. There are a lot of problems, I think, where a lot of research in other places are very what we call siloed. There's the scientist here, there's the patients there, there's the doctors there. And this alliance brings that down. We're sort of the eHarmony or the Bumble of research in a lot of ways here. Um, and frankly, I think, as I mentioned before, this is a great place because it provides a voice to patients. And I want to hear your voices tonight as we all do. So let's start with a little bit of background here. One of them is that people start throwing around these letters and acronyms, an IRB and an ABC and a 123 and an IR what. And one of the most important things is an IRB. And what is it? It's an institutional review board. And so this is something defined by the National Institutes of Health, the NIH. It is an administrative body, so it's a group of people that reviews, approves, and monitors research projects that are involving, in this case, human beings. The goal of these IRBs is to make sure that the science that's done is ethical. We're not sort of just grabbing people against the will and injecting them with, gamma rays or Spider-Man stuff or anything like that. And it's designed to protect the rights and the welfare of the participants. These IRBs are mandated. They have to be done for federally funded research, at least here in the United States. And their goals are to evaluate these studies for safety, for risks, and for informed consent. People should know what they're being engaged in. Um, and you do need to get consent for most studies. So, IRB is a really important thing, and it's there to protect patients. Now, when you do science, a lot of times you hear about clinical trials. And so, there's a general, hey, it's a clinical trial, but there are lots of different kinds. And again, to try to get everybody on the same vocabulary, and it's still, I struggle with this a lot. There are sort of six big kind of clinical trials or studies. There's treatment trials, and these are the ones I think that a lot of people think about. This is you're testing some treatment. It can be drugs, it can be radiation, it can be surgery, but the goal is to use some sort of new treatment and find out if it makes the disease better. There are prevention trials. And so this is something where you say, well, gee, maybe we can't treat the disease, but if we can stop people from getting it or, getting sick, that might be great. And a great example of this is vaccines, one of the most, incredible advances in science ever. And other things are like lifestyle changes. Maybe if you don't smoke 18 packs of cigarettes a day, you can lower your risk of cancer. So, that helps as well. So that's prevention trials. Diagnostic trials are trials to try to get better tests. Can you find the disease maybe at an earlier stage? Can you figure out if the disease is susceptible to certain treatments? So it's a diagnostic trial. Screening trials are ways to use methods or detect things specifically very early in their disease. How prevalent is it in the population? How commonly are people affected? So that's a little bit different than diagnostic trials because you want to find something specifically early in the stage. Quality of life trials or supportive care. These are trials where you say, well, if someone has a chronic illness, if they're living with diabetes, if they're living with, hearing loss, if they're living with, familial CCM, for example, how can you make sure that the quality of life is the best it can possibly be? And these are really important studies. You don't always need a silver bullet, but if people can live great, full, wonderful lives, that's important to know. And the last thing are natural history studies. What happens if you don't treat a disease? Because sometimes treatments have risks, but if you don't know how risky the thing is by itself, then you don't know if the risk of a treatment is worth it. And so if a disease only causes a 1% per year bad thing of happening and a treatment causes a 20% risk per year of bad thing happening, maybe the natural history is better than the treatment. So these are the kind of trials that I think they're really important. Um, I did mention that the one people most talk about are treatment trials or drug trials specifically. And this is the one where they talk about phases. And this isn't Star Trek with phasers where you're trying to knock people out or fight the Klingons or something. And these are very commonly used when you're talking about drug trials. And the Alliance has obviously been very involved with these, a lot of other groups. And there's really four phases. So phase one is really just to sort of get a sense, is the drug or the agent, whatever you're giving, is it just safe to take? We're not necessarily trying to find out if it cures the disease at this stage. It's just to say, boy, can you even take an aspirin? Is it safe to have a blood pressure pill? Or is it going to give you, all of a sudden, are you going to sprout hair out of your eyebrows or you're going to change, colors or grow 10 feet tall? So phase one is just to say, can you safely take this drug? What's the dosing? How do you get it into somebody? Phase two is, once you've determined what the right doses are and that it's safe, hopefully from a phase one trial, is to say, okay, can the drug have an effect? Does it actually treat the disease you're looking at? And does it have a safety profile that's allowable? This is sort of saying, all right, we know what dose to do. We know it's safe in people in general. Now, is it safe and actually having an effect on the disease or the problem? Phase three is the biggie, right? That's the one where you talk about, is it a randomized trial? Meaning if I just have 10 people that have this disease and I give five of them the new magic drug and five of them either nothing or five of them the standard of care now, if you're trying to two antibiotics, which one treats germs better? This is sort of the way that you establish what does it actually work in the real world if you sort of blindly compare the current status to the new thing. And then lastly is phase four, which is after you've done it and you've used the treatment, post marketing, after it's been out there. This is the long term, are there weird stuff that crop up 6 months later, 6 years later, 60 years later? And does it continue to be effective? Or, for example, with antibiotics, maybe it's amazing at stopping an infection, but boy, do all the germs become resistant to it and immune to it essentially after a period of time. So those are the kind of things that we talk about in terms of clinical trials and the phases. You know, Part of that also is we've talked about the phases, but there's also all these crazy studies. And I promise that I'm almost done with this vocabulary stuff. I wasn't very good at vocabulary in fifth, sixth, seventh grade. Those were the best 15 years of my life. But, so in terms of the studies, there are sort of five biggies. So the one everyone talks about a lot are randomized controlled trials. This is sort of the gold standard where you say, I've got my magic new thing I want to try. And I got the thing that always works. So maybe you take a Tylenol for a headache and they got the new wonder drug. So you have people come in with a headache and you kind of razzle dazzle and you pick out of a cup and you say, well, you're either getting the Tylenol or you're getting the magic new thing. Which one works better? So that's a randomized controlled trial. And there's all different ways to design them, but that's the core of it. There's observational studies. So this is where you observe people in the trial, but you don't intervene. And you just say, are there risk factors in there that we might need to know about that could affect, are certain people more or less capable to benefit from an intervention? There's a thing called a parallel group design. These aren't parallel bars like you have in your gym, but basically you stay in one group. Either you're getting a treatment or you're getting, a placebo, a fake thing for the whole trial. And that way you can kind of see how they do over time. There's a factorial design. So this is a little more complicated. This might be where you're trying to do two different things at the same time. Do you cut out a cavernous malformation and then treat the bed with medicine or radiation after? And you sort of do two things at the same time, sort of sometimes done to be more efficient or to see if there's a synergistic effect between two different agents. And then lastly, very complicated are these block designs. So, for example, you may say, well, we've got a drug. maybe the drug doesn't work for everybody, but maybe it's a good drug for people in their 50s. Whereas maybe people in their 20s or pre-hormonal kids, maybe they shouldn't get the drug. So, or, maybe there are certain locations that in the country that might be more or less exposed to sunlight or cold weather or whatever. So these are sort of looking at other factors that might impact the effectiveness of your treatment. Now, again, this is a big mouthful. Hopefully, we'll sort of wrap this up a little bit. I want to give some examples of what these are really like to sort of bring home all the blathering I've been doing. So, one example, a very classic one is the treatment example. And, so people have kinase inhibitors or ROCK inhibitors. This is a classic example where they say, look, we know there's this chemical, this protein in blood vessel cells called a kinase, ROCK, basically. It's not the big bald guy who's a big movie star with a lot of muscles. Those may or may not be present in blood vessel cells. But people have theoretically assumed that this enzyme, this kinase, is important in the normal function of endothelial cells. If this is screwed up in cavernous malformations and you have a drug that can affect it, will that possibly help to reduce the damage or the problems associated with cavernous malformations? And so essentially this trial, which, the Alliance was involved with, is looking at this, NRL 1049. It's a ROCK inhibitor or ROCK2. It's one of a very specific subtype of these drugs. And they basically tried to understand if you give this drug, is it safe? This talks about, for example, the side effects. So people had some headache, they had some dizziness, but no big major side effects. And they figured out what the dose was that was appropriate. And then what they did was they measured the level of this chemical in people to say, is the drug getting absorbed and is it affecting the metabolite, the chemical effect that we're looking for? So it's a very easy example of something that was done here in the real world as a treatment drug. Another example is a quality of life study. I mentioned that's another one. And this was, a great study done by the group here with many investigators from the Alliance. They had a really cool acronym, PROMISE, Patient Reported Outcomes Measurements Information System. People like their acronyms. But the idea was to say is if you looked at this scoring system, different qualities of life and, how do you feel about your day? Can you get around okay? How is your anxiety? Things that are really important for day-to-day life that maybe you can't measure with a urine test or a blood test, but manage, they affect how you live. And what they found is that this is an important and good way to measure quality of life in people, and therefore this grading scale can be useful if you're trying an intervention in the future to say, well, maybe the intervention changes the metabolite levels of something, maybe it reduces the amount of cavernous malformations that are present on a scan, but does it help the quality of life of patients? Because that's ultimately in many ways what you're looking for, and it's important to think of. Natural history. I mentioned, well, how risky is this thing by itself if you just are out in Alaska or on a desert island somewhere? And can you figure out, does that merit something? So, for example, if you look at, this is a paper we published looking at the natural history of cavernous malformations in kids. And so, what is the bleeding rate if you have just a single cavernous malformation that hasn't bled, that just shows up because little Timmy or Susie fell off the bus and hit their head? Well, the bleeding rate, is probably pretty low for these spontaneous, non-bleeding, non-symptomatic things at about 0.5% per year. So that's important to know because if the risk of surgery is very low at 3%, but the risk of bleeding and problems is 0.5%, you got to make a good case as to why the heck you're going to have a surgeon doing surgery. And that's why sometimes we say, even if you have a cavernous malformation, and we know for a fact it's in there on the scan, we may say, because of this natural history study, it is actually lower risk to do nothing than it is to get rid of it. And again, these affect, has it had a bleed? Does it have a seizure? Does it have symptoms? A lot of factors. But this is important foundational data that you need to sort of get that answer. Another way you might use this is to say, I get asked a lot, hey, doc, what if little Timmy or Susie, they go on a roller coaster? They got a cavernous malformation. I want to go to Disney. My kid wants to play sports. They want to do volleyball. We live someplace where we get influenza every year. Well, this is a natural history study to look at lots of people that have these kinds of vascular conditions in their head for kids. And you can look at them and say which things may increase the risk of bleeding and which ones don't. If, every kid that went on a roller coaster that had a CCM had a brain bleed, maybe you don't go to Disney. Well, that's not really the case, thankfully. So you can pretty much do a lot of these rides unless they're really, really violent, crazy ones. Infections probably don't increase them. Most sports are probably fine. So this is an example of a natural history thing that answers a really important question that then goes on to affect the quality of life. So what do we do with all this research? I hope I've given a few examples, but how do we as physicians use it, and how do people as patients, how can they benefit from it? Well, here's an easy one. You know, we have found from the natural history that if you have a cavernous malformation that bleeds, the highest likelihood of it bleeding again is within a 5-year window. Well, doesn't that tell you a lot that if you're worried, maybe if you have a little kid, you can say, all right, we're going to get a scan once a year for 5 years. But after that, we know that the bleeding rate really levels off. It's much, much less. So if we can get through that 5-year window and it hasn't bled again, we don't have a crystal ball. Every person's individualized, but we can tell you with pretty good confidence, at least in the population, that bleeding rate is going to be very low over that long period of time. So that helps us relax a little bit. And this is a real world way that how often you got to go to the doctors, how often you got to get a scan, when should I relax a little bit. So that's one example of how we do it. Another one is to say, well, okay, can we do research to understand how effectively surgery can stop seizures? And what we found is if you just take out the malformation, even if you don't use neuromonitoring during a case, even if you don't take out the hemosiderin, the sort of tattoo stain around it, you are just as effective in stopping seizures in most cases. So you don't have to increase the risk of the surgery. You can do a shorter, smaller, safer surgery with lower risk of infection because we found that the cure rates are the same. And so that's really important for people. This is another example with lobar cavernomas. We can do research and show that that seizure rate can get knocked way the heck down just by taking out the lesion. And we wouldn't know this if we didn't do these kinds of clinical studies and this research. So you may ask, well, how does this, impact care? Well, I've showed you some examples of, first what all the words mean, then some real world examples of what the research is, what the data is. What do you do with all that? Well, this is the answer. I mean, this just came out this past year in April. These are the guidelines. So every few years, we take this kind of research, we listen to the patients and say, what's important for us to know? We do the studies that I showed you that are, those individual papers. And then these guidelines take all the papers, and sort of take the best, the latest and greatest hits. It's like a, top 100 radio station or something. But we try to synthesize them together and put together practical, how do you do this in the real world? And I think this is a huge success of this organization to figure out what studies need to be done, get the studies done, and then weave that information together into a comprehensible, real set of guidelines that are like driving instructions for both doctors and patients. And so I think this is hopefully a real example of that whole pathway. And I wanted to cover a little bit of what research is, what the words are, some examples of research, and then what the end result is, specifically with this group, which is a great group. So that's the big part one of this talk. The next thing I want to talk a little bit about is we've talked about what the past research has been, what's going on now. So how can we treat people better? I talked about how treatment is one of the big things that people are interested in. Um, I'm a surgeon, so let's talk about ways that we can make surgery safer and better. How can we get where we want to go safely? It's the brain. I mean, it's kind of important. So, we have tricky spots. A lot of people talk about brainstem cavernomas. It's not rocket science, it is brain surgery, but we've done research to find ways to figure out how to get to these previously inaccessible lesions so that nothing's risk-free, but hopefully it's a lot lower risk and easier to do. And by figuring out where the corridors are that allow you to get to these things, and we have a paper that just came out or is in publication now that really helps us understand when someone comes in with a brainstem lesion, can you get it out and what's the risk of doing that? Now, there's also ways to do surgery that's less invasive. And this is using, for example, ultrasound. I'm not talking about focused ultrasound, which I'll talk about in a few minutes. This is just using the picture ultrasound like you might have for a pregnancy or a sore elbow in the sports medicine office or something. But this is the idea of saying, can we use ultrasound in the operating room, where the idea is to say, how do we do this? The brain moves a little bit when you move your head. And so you say, well, don't you have those fancy 3D navigation things where you put up a computer screen like Iron Man, in the movies? Yeah, but in the real world, the brain moves a little bit when you open up the head. Water gets in and out and air bubbles move in and out. Ultrasound is real-time imaging. And what that allows us to do is to put a little catheter in exactly to where the lesion is, especially if it's deep. And what that allows us to do is to get things out safer and faster that adjusts for the real world moving. Again, not rocket science, but it's research and it's important. What other kind of treatment research do we have? Well, I think a lot of folks are probably familiar with this idea of LIT, uh, imaging, laser treatment, where if there's some places that are deep in the brain that are hard to get to with a surgery to go in and take it out, sometimes you can put this little tiny catheter in. And if the lesion's in the right size and the right shape, we're starting to learn how you can use a laser to shrivel these up, and you might be able to treat them with that. Even if you can't treat the cavernous malformation, sometimes, we're doing research on how these lasers can create a little firewall around the cavernous malformation and maybe reduce or even stop the seizures by breaking up the signaling of seizures around there. I mentioned there's focused ultrasound. So just a slide or two, I got to talk about ultrasound imaging, which is looking at it like a picture so you can cut it out. You can also do focused ultrasound where you can see here with this very high-tech image, just like the Death Star here. That's my fancy neurosurgery image. But the difference is all those beams converge on one spot, and that can help to essentially destroy the tissue that might be a cavernous malformation. We're very excited about, some work has been done in adults. And we're trying to do that in kids now as well. And the third thing I want to talk about, and I put 3 for 3D, which is pretty good. There's 3D printing. And so this is something we do at Children's to say, if you have a very complicated lesion and it's hard to reach, you can do the surgery before you do the surgery. This is the idea, again, of practicing or researching. The idea would be to say, if you have somebody coming to our hospital, you don't have to do this for the vast majority of cases, but, a few times a year, you might have a very complicated one. You say, well, what's the right way? You don't want to be practicing the first day in the operating room. So you can get their patient's films. We have a facility center that does 3D printing, just like you see for these things on Etsy and eBay and everything. But instead, we can do it to build models of the brain that allow us to, look at things in real world 3D ways and practice surgery. This is just an example where we have a printing press, and this is a patient's actual CAT scan and MRI, where they can build this 3D model for us, and it's incredibly helpful. I will show you an example. This may have some pictures of surgery. So if you are grossed out by surgery, I just close my eyes and don't look, but just a little trigger warning for people in the crowd. So what we can do is, this is not a cavernous malformation, it's an arteriovenous malformation, but it's the same idea. This is kind of deep in the head, it's hard to get to. So we built a model to understand where the safe parts are, where the bad parts are. We can build it regular size, extra big. We can put it in a 3D clear plastic model, so you have like Superman X-ray vision. And then during the surgery, you actually can have the model in the operating room, and it's 1 millimeter to the right or 2 millimeters to the left. And you've already practiced the surgery 2 or 3 or 4 times before you even bring the patient to the hospital. As a result, when I'm doing this surgery in a deep place, I have a lot more confidence in where I'm going. I've already practiced on the field before we've done the surgery. And the result is such that, we can take these things out with lower risk and, frankly, over faster time. This was written up in one of these sort of fancy pants magazines, but essentially, we can show that our models are 98% exactly matched to the real world, so very high concordance, less than 2 millimeters of difference between the real world and our models. And in addition to this, it reduces OR time by about 12%, which not only saves money for the hospital, but more importantly, the less time you're under anesthesia, the less blood loss you have, the shorter your recovery is, and the quicker, hopefully, you get out of the hospital. So, this is a great tool, I think, that has been very, very helpful to us. Now, this is what they do to me when I'm not speaking on Zoom. You know, they lock me in the box. But are there other ways we can sort of think outside the box to think about stuff? And this is the last bit of the talk. So I talked about what all the different kinds of research are, some of the surgical research, actually cutting and sewing. And the last bit is sort of what can we do at the bench top? And this could be hours long, but just for the last sort of 10 or 15 minutes here, there's lots of new ideas, many of which have really been built up and successfully advanced through work with the Alliance. I mentioned earlier, drug therapies are a huge one. There's the ROC inhibitors, and while one of the trials didn't work out as well as some of the folks might like, it doesn't mean that this is not a great success. And the molecular understanding we're having of these cavernous malformations are really pushing the field forward to help us. I hope, in the next few years, have incredible advances for drug therapies that might reduce the risk of these in many ways. Seizure, bleeding, growth. There's lots of opportunities. We are learning that inflammation is a big part of some cavernous malformations. So if we can modify the inflammatory response so we get the good inflammation we want to help control it, but reduce the bad inflammation that makes people sicker, it's a delicate balance, but that's a great role. Beta blockers and propranolol are certainly something that people are thinking about, and are there different subtypes of that might work? Can we work on controlling the growth of blood vessels, angiogenesis? Can we turn it on where it's needed, turn it off where it's not? Are there statins that might be helpful, which are traditionally used to control different types of diseases? Get your cholesterol and things like that. Well, might it have a role in here? There's been in the past several years a lot of study around the diet. Does the microbiome, all the little germs in your gut, can they affect how likely or not likely it is for them to bleed? Are vitamins and different types of dietary changes potentially able to affect how your cavernous malformation behaviors are? So these are really important things, I think, that are at the cutting edge of where we're learning. They're not gospel yet. There's a lot that we need to do, but I do think it's a great example of how we're pushing the field forward. And thinking of pushing the field forward, that's a good segue on guidance factors. I'd say push things forward. This is a little bit of a nerdy joke, but I'm sure you're all laughing hysterically in Zoom land. This is something that we do in our lab, and I want to end with a little example of some of the work that's going on at Harvard, at Boston Children's. Again, there's tons of other way smarter people than me out there. I don't mean to imply that this is the latest and greatest in the world, but it is something I think that we've had some success with, and I think has some very important stuff. Axon guidance factors, or AGFs, what are they? Well, they're proteins, right? They used to be amateur teens and they got really good. Now they went pro. No, nothing. Okay. They're secreted, meaning that they're not trapped inside of the cells. They're squirted out to do stuff. And that's wonderful because you can measure them. And that helps the science. You can also administer them or block them because they're outside of the cell. They're originally part of brain development. They're kind of like sleeper agents, where in real normal situations, most of these are designed to build a brain, to build blood vessels in pregnancy before birth. And then they are supposed to turn themselves off when the baby is born or even earlier in development. They influence really important things like migration of, where nerve cells and blood vessel cells go, invasion of, when blood vessels are supposed to grow into parts of the brain or not, and angiogenesis, this blood vessel growth. The other thing is they usually act in pairs. There's a good guy and a bad guy, right? There's Superman and Lex Luthor. Pick your Batman and the Joker. I don't know. That's all I got for superhero stuff. So that's important because it means you can turn them off and on depending whether you use what's called the agonist, the go, or the antagonist, which is not like your aunt and uncle, but stop and go. These are a whole bunch of the what we call canonical, the classic proteins. The big one I want to talk about is ephrin. Ephrin is, not the name of a weird uncle that shows up every holiday and says, inappropriate things at the dinner table, but rather it is one of these very important canonical proteins that drives blood vessel growth. Um, this axonal guidance factor, ephrin, is really important in growing blood vessels in the brain. And so when you look at this, there's this, the what's called the receptor. This is like the grabber that's a periscope that sits outside the cell, and it looks around and says, okay, if there's any ephrin B2 around, I want it. Ephrin B2, if ephrin B4, the receptor is like the baseball glove, ephrin B2 is like the baseball that gets sent there. So if you throw a lot of ephrin B2 out, then the ephrin B4 glove will catch it. And when it catches it, that turns on a switch and makes the cell do stuff. And so when that happens and that is turned on, when that ball of ephrin is caught by the glove, it's just like you tag the batter out in baseball. I'm doing a lot of sports analogies. I'm not a very sportsy guy. I'm a nerdy neurosurgeon. But the idea is that this set of chemicals can make blood vessel cells grow or stop growing. And you can imagine that's pretty important in cavernous malformations. For example, when you look at cavernous malformations, they grow in a similar pattern to the way that ephrins cause blood vessels to grow inside of the brain. And so when you look at this, this is an important observation because you could imagine that if this normally drives good blood vessel growth when things are in balance before birth, what happens if that balance is off? Well, maybe you get bad blood vessel growth. And that's, in fact, exactly what happens. If there is an imbalance between too much ephrin B2 or too little ephrin B4, essentially, if you're pushing on the gas more than you're pushing on the brake, the car is going to go faster than it should. Not that I've ever gotten a speeding ticket, but that's the idea. And so we had this idea that if this happens in birth, if this happens in development, and if we can see that there's this imbalance between ephrin B2, the ball, and ephrin B4, the catcher, maybe that might also be happening after people grow up and they have cavernous malformations. So this is important because if we think these chemicals might be involved in making bad cavernous malformations, well, this is really important because you can measure them. They're a diagnostic tool, right? You could say, well, cavernous malformation be treated? Is it a biomarker? Can I find out maybe without MRIs or with fewer MRIs? Could I do better with my testing? Um, it's amenable to manipulation. If there's too much or too little of something and it's circulating around, you can either vacuum up the bad stuff or put in extra good stuff, and maybe that can restore the balance. And the other thing is, you could do long-term surveillance. For example, we do a lot of work with urinary biomarkers, which I hilariously put in yellow font because of P. But the whole idea is that urinary biomarkers might be a less invasive way to monitor this disease. This is an example of a paper we published a couple of years ago where we found that by peeing in a cup, you can pee in anything really, but we use cups because it was better. We can not only determine if you have a certain type of brain disease, but what kind of tumor you might have, what kind of blood vessel malformation you might have, and if it's coming or going. So this was really important, and we're investigating this now. We've also found that on top of measuring if there's a disease there, we can show that by altering the amount of it there, we can control how good or bad the cells behave. So, for example, these are normal blood vessel cells, and they kind of just sit tight. They're just kind of swimming laps. They're behaving. They're staying where they're supposed to. When you have cavernous malformations, they go, woo, party time. And they start zimming off wherever they want because they don't stick together the way they're supposed to. Well, guess what? If they're not sticking together well, that might cause them to expand and create those bubbles that you see in cavernous malformations. So this is a real example of if this balance is off, it goes from a nice, healthy, tight little space to big, goofy things all over. Um, and so we looked at this in actual cavernous malformations, and we found that this protein is imbalanced in cavernous malformations, and that we can give or remove some of that protein to get it back to normal. So this is really exciting to see. Why does this happen? Well, what we also found is that if this is the lining of the cell and this is that efferent B4, that baseball glove on the surface that catches, the signal, what it does is when I said it turns on a switch inside the cell, it turns on all these different chemicals in a pathway. And why is that important? Well, because all those little pathways, each one of these can be mutated, changed, or drugged to affect disease. So, for example, that efferent, when it's abnormal, on one level can cause cavernous malformations. If it's a little lower down, it can cause another type of blood vessel malformation called a venogalin. And a little lower down called RASA1, the next step down in that same pathway, it can cause big blood vessel malformations in the spine and in the brain called arteriovenous malformations or fistulas. And we've also found in cavernous malformations, if it's mutated, it is something that may drive the formation or the maintenance of cavernous malformations. And in fact, we published this just this past year and a half ago. And then we was in the New England Journal review that we just had, adding to the number of molecules that we're still learning about. They're not ready for prime time. But the takeaway is if you look at this pathway by doing research, by trying to understand why they're there, this one efferent molecule at the top, the literal tip of the iceberg, showed us all the other molecules downstream under the iceberg, under the water, that are part of all these different vascular malformations, including CCM, that now may have novel and new drug targets that we could hit. And some of these already have cancer drugs that we might be able to repurpose into cavernous malformation drugs or other vascular malformations. So this is really, really exciting because now we have this great model where we can look at patients at high volume centers, centers of excellence like CCM. With partnering with the patients, we can get these samples. And this is why it's so important for patients to participate in research. We need tissue, we need MRIs, we need people to tell us how they're doing. And we can analyze the real world samples, then study them in animal models, in petri dishes, look at the molecules that are there, and then hopefully go back with that information to understand how to better diagnose the disease, how to understand the risk of it. Maybe it's a bad guy, maybe it's a good guy, and then ultimately, hopefully, develop better treatments for disease. And so, this is a real paradigm shift in how we're doing science these days. And I just think it's incredibly important because of two things. The first is the sort of growth of technology to do this quickly, effectively, and across multiple centers, especially when coordinated by like an alliance like this, means that the rate of science is just accelerating, which can be scary, but is also great. The second thing is this paradigm of research, while it's so effective, it does not work without patient engagement and patient and family involvement. And we really need to partner with all of you out there that are patients and families, with all of us who are physicians and scientists to make this work. It is incredibly effective when it works, but it does not work if it's not a team. So, in conclusion, I've been throwing a lot of science stuff at you. It's an incredibly exciting time to do research in general in the biomedical field, but especially in the realm of cavernous malformations and CCM for all the reasons I mentioned. We're understanding the molecules better. We're developing small molecule therapeutics and drugs. We're getting new surgery approaches. And really, in part due to organizations like this, we're getting a lot of that other information about quality of life, what's important to the patients, and how to do that together. So to wrap up here, and I'll open the floor to questions after this, but cavernous malformations, I don't need to tell this crowd that it is a significant healthcare burden, not just for the patients themselves, but for their families, for the people that their loved ones. It is really important to improve the outcomes. I'm focused on children as a pediatric neurosurgeon, but I heard that adults are important too. So everybody that have CCM, of course, are really important. And this needs to be where we get multiple disciplines and we need to learn from each other and innovate across the traditional lines of study. It can't be just the surgeons learning how to have a sharper knife. It can't just be the molecular biologists doing petri dish work. It can't just be the patient families doing longitudinal, history studies. We need to cross disciplines and work together. Break down those silos, again, be the e-harmony of research. I think stratifying risk through these big population studies, coupling them with genetic testing and biomarkers in particular, can really help us to get the best individualized treatment plan. And I really think we're moving towards, taking population data, but using that information, and that's AI, that's computers, that's big centers. But the goal is to create not a population treatment, but an individualized treatment. And I really think that we're getting to the point where we're able to do that so much better. Um, Patients and families with cavernous malformations, I think, are already benefiting from these novel approaches. These are everything from the better surgeries that we're doing. We just had a kid we operated on, on Wednesday afternoon, and they went home this morning. I just saw them in rounds today. Did a craniotomy, took it out, minimally invasive with some of the stuff I showed you, and less than 18 hours between getting brain surgery and going home. I mean, just really incredible. The molecular biology is just so exciting. The new imaging techniques, MRI, ultrasound, 3D printing. I really think that across the board, we can harness science to become so much more effective to make the quality of life of our patients and our families better. And I would end with the fact that I think all of us, the scientists, the clinicians, the administrators, the patients, the families, together, we have an obligation. I feel this very strongly. I tell my trainees this, I tell my staff this. We have to push the field forward, and that is only done by guiding and engaging in translational research. We can't put our heads in the sand. We can't be happy with the status quo, and we can't do it alone. We have to always strive for better. We have to do it as a group. And I think it involves listening to everybody and recognizing that, this is a team effort. So I hope I didn't overwhelm you too long, but I really am very, very passionate about this. I think it's an exciting time to be engaged with this. And I really think the Alliance is at the forefront of the medical organizations, the patient organizations that I think are pretty much the best in the world that I've seen. I've been all over, and I can't compliment the team well enough. So with that, maybe I'll zip my fat lip here. I will stop sharing, and Katie, you can be the MC now and zip my lip and open the floor to questions for the next however minutes until I go, until they boo me off the stage.
Oh no, I was gonna tell you there are such nice comments for you in the chat. You might be, I think you can see the chat on your end. People really responded to the 3D printing and mapping. Lots of comments of wow, an incredible use of technology. And then also folks are really impressed by the humor and the dad jokes. They say the dad jokes are strong tonight.
Wow,
So
that's
love
all
his
I got.
humor.
That's doing my best.
You're doing great. You're doing great. So we've got a number of questions here in the Q&A. I think the first one to start with is a couple of folks have asked kind of what you're most excited about from a CCM research perspective. Like, what do you think is kind of most promising? What's most exciting for you?
This is going to sound cheesy, but I really think that it is the alliance coming together and building this coalition
Mm,
because I can point to any one thing, right? But
right.
we're not going to cure this with one pill or a better surgical approach or a fancier MRI. The fact that people are taking their time and effort, and this includes patients and families, doctors, administrators, everybody, to say, look, we can't do this
Yeah.
alone. And there's really just been I've been with this group for a long time, and I'm just so impressed with the way it's upticked in research. Connie, as you know, has been sort of one of the leaders of this group for a long
Yeah.
time. She's always been a believer in this, but now I'm really seeing the group sort of as a cohesive entity doing that. So I would say that's the most exciting thing. Obviously, I'm biased if you're talking very granular. The molecular biology, I just think is going to be one of the big advances. Not everything's going to be cured with a pill or a drug, but I am telling my patients as children, pediatric patients, not today, not tomorrow, but in their lifetimes, I firmly believe that there are going to be a lot more treatment options that are druggable
Mm,
treatments, and I'm hoping I'm out of business not wearing these scrub pajamas anymore. I can just do all my work from Zoom rather than just the operating stuff.
great, great. We've got a few questions too about focused ultrasound.
Hmm.
And people are asking, my understanding is that they've used focused ultrasound in other conditions, right? They've used it for Parkinson's disease, they've used it in adults. And we're trying to get a clinical trial off the ground, right, to see if it works for CCMs. So somebody asked, do we think it'll be used for folks that are non-symptomatic or that, have a lesion that's not causing problems? And do we think it'll be used for kids, or will kids be part of the clinical trial? Do you have a sense of that?
Yeah, the answer to the short one is probably yes to both, but not for a while. And there's a very easy answer for that, I think, which is whenever you're trying something new, it's like with my kids, right? If they say, hey, someone's got to jump off a big rock into the water to find out if there's enough water to swim in and it's safe, you're not going to have your sweet little, my kids are all grown up now, but whatever, your 10-year-old daughter or son and push them off first. You're going to have the old geezer who's kind of useless and let them go first.
Oh,
And I'm saying that jokingly, but the point is when people do clinical trials, when they're trying something new, you're going to usually do it in the highest risk populations first
mm,
because those are the populations that have the most
right,
to gain and the
right.
least to lose. Whereas if you said you had a little 3-year-old sweet kid that has no symptoms and a little tiny malformation, it's going to be hard to say, boy, I'm going to try a new drug or try focused ultrasound or try an experimental treatment on that child for that. On the other hand, if you had some, you know, mid 50s person like myself with a brainstem cavernoma that's repeatedly bled and is potentially
Uh-huh.
fatal, well, then, hey, you know what? Give it a shot because
Yeah.
I am much more willing to assume the risk of an experimental treatment where my again, natural history, quality of life, you need these studies, but that will justify it. If my natural history has a 50% risk of something bad happening, well, then maybe a
Mm,
25% risk of an experimental treatment is worthwhile. On the other hand, if you have a little kid who has a 1% risk of bleeding or problems, you're not going to try a 25% clinical trial. So, yes, I think focus ultrasound is going to be very helpful for many types of cases, not everything, but many. But I do think it will start with the high risk, symptomatic, scary stuff because that's most justified. And I think that's where we need the most advances. That's where it can help the most. Then once you've proven its efficacy and you've kind of, dialed it in and got it to what's safest, what's not, how much, what's the dosing, what's the amount, then you can try it in asymptomatic lesions. And then maybe finally you can try it in kids. So that would be my long-winded answer to that very good question.
there's a comment that says, I'm an old gizzard and I'm ready to jump.
Well, you and me both. So, but yes, I'm on board.
And what about somebody asked you about like an acute lesion, like where somebody that's having an active bleed, like how does that fit into like understanding focused ultrasound?
So again, this is all brand new, and I don't pretend to have the answers as I don't think anybody does. But
Yeah.
by and large, you know, any acute bleeding is going to be very, very hard to do treatments that have presumably a delayed or
Mm,
uh, either an onset of effect that takes a while to work, or an onset that might cause more swelling or problems before it gets things better. So, for example, let's say you had a brainstem lesion and it was repeatedly bleeding. And every time it bled, it swelled a little bit and it caused some
uh-huh.
symptoms. You might use focus ultrasound, but you might wait for a window of time where the bleeding has receded. And then when you zap it with focus ultrasound or lit or whatever, then you can tolerate a little bit of the treatment induced swelling with fewer side effects. If you already have swelling because it just bled and things are kind of symptomatic and bad, and then you
Uh-huh.
zap it with focused ultrasound or lit and it swells even more, well, then
Uh-huh.
that might make it even more dangerous. So again,
Okay.
these are all to be determined, right? TBD, I think the
Right.
cool kids say. But the general principle, in my opinion, would probably be that you would probably want to use those kind of things, focused ultrasound, lit, etc., when you have a quieter period and you can absorb a little more swelling and have a little more wiggle room if there's side effects from the treatment, in my opinion.
Makes sense. And somebody would like to know who you picked to win your March Madness bracket.
I gotta be honest, I have no idea who's in it. I really don't. My dad is like the biggest sports fan in the world. One of my groomsmen in my wedding runs this huge sports agency, and they don't understand. But I'm just I hopefully I'm not all thumbs in the operating room, but in baseball, and basketball and everything else, I my famous story, since we have 1 minute, is the coach used to go around and put his hand on the shoulder of everybody that was going up to the varsity. And so I grew up in Massachusetts, and coach walks up to me and he's going to put my hand on my shoulder. I go, "This is it. I'm going up to varsity at Dartmouth High
Uh-huh.
School, and then I'm off to the Red Sox." But he puts his hand on my shoulder. He says, "Smitty, have you thought about track?" And that was the end of my baseball career. And so baseball, basketball, you name it. I don't know, but I'm just a general hometown guy for any Boston team that may or may not be in it.
Love it. Love it. Love it. Um, we do have I think maybe we have time. I was hoping you could just we've had a couple like sort of clinical questions too. So I was wondering if you could just talk a little bit about your second opinion program at Boston.
Sure.
And then I've also, folks are welcome to email me about it, but since you're here, if you don't mind telling us
Yeah.
a little bit about it,
No,
yeah.
absolutely. First of all, our job always is to put the patient first. And in second opinions, I always feel that it's always a good idea. If it's a big decision, if you're going to buy a car for Pete's sake, you should get a second opinion. So I say that because we don't pretend to be necessarily any smarter or better than anyone else. There's a lot of awesome folks out there. There's a lot of centers of excellence, but we do see, I think, the highest volume of this for kids in the US. And as a result, I hope we've got a lot of really smart people to lend advice. So that's the why of the second opinions. The how is we've got several different mechanisms. So there is a formal online system where you can get a written opinion through different groups that Children's runs. They're called SUMIS, I think, and a couple other names. They're on our website. And what happens is there is a fee associated with it that's run through a third party, and they give us the films and the records, which are uploaded, and we go ahead and do that. The third way, which is the way that I think is also very easy, if you have a specific question about a CCM, you can just reach out to us directly with no third party, and we will, for free, our group has a weekly meeting, and we are happy to review films and cases for no charge. And, we can give you a quick call or a quick opinion. Obviously, if it's a hugely complicated thing and we have to bring in multiple other specialties, we certainly are happy to do that. But many questions we just are happy to address directly. We have what's called a Tuesday review with a weekly meeting with
Mm.
our team. And again, it's on the Boston Children's website if you look up CCM or Ed Smith, and we're always glad to do it. We think it's really important, and we're also happy to talk to your local doctors. We're happy to talk to your local primary care doc if they're confused on what's going on, or your local surgeon, neurologist, whoever. Our job again is most importantly just to get you feeling better and help out in whatever way we can.
I think there's just maybe one more question, if that's okay.
You bet.
Um, Somebody asked about biomarkers. They keep hearing that term, wanted to hear a little bit about kind of how that fits into all of this.
Yeah. So biomarkers are just a fancy pants nerd term for, are there different ways that you can monitor or mark a biological process? And there are all different kinds. The classic ones that people think about are chemicals, right? So a lot of people know an easy one is sugar. If you have diabetes, you can prick your finger, you measure the amount of sugar in your blood, and your blood sugar is a biomarker for different types. You could look at, for people with prostate cancer, there's a thing called PSA, prostate specific antigen. You get a blood test, and if it's going up, you might need to get checked for prostate cancer. So we are looking at different chemicals, that axon guidance factor, ephren B2 and B4 that I mentioned. You can measure it in the blood, in the urine. We're looking at spit. And those are ways that we can say, well, if they're up compared to a normal population that don't have CCM, or within their own patient, if you had a big CCM and your levels were here, then we treated it with ultrasound or surgery, and it came down to here. Well, we could use a biomarker. We could just maybe have you pee in a cup and mail it. That puts the P in UPS. And the advantage there is that maybe instead of getting a scan every 6 months or every 3 months, where you have to drive into the city, you go to sleep, little kids need to be sedated. Maybe instead you stay at home, you pee in a cup, you mail it, and we could say, well, hey, if that's normal, maybe you don't need a scan this year. You save 4 grand or so, or a copay for an MRI. You don't have to travel in the city, take a day off, be sedated, not to replace MRIs,
Mm,
but to help. Now, there's also genetic biomarkers, there's radiographic biomarkers. You can look for, is the gene, when people say CCM3, those are genetic biomarkers. Do
right.
you have that mutation in your blood? So that's a long-winded way of saying it, but basically they're different, usually chemicals, but they can be other things that give you some information about how good or bad or changing a specific disease state might be. Does that answer things pretty well? All
It's
right.
amazing. Amazing, right? And 1 minute to go. You did amazing.
I'm sweating. I'm very nervous. I'm shy, which is one of my big faults. So anyway,
Here's,
any last minute stuff before I wrap up here?
I just have one quick thing. People want to know, how can we find out about research opportunities at specific hospitals, or how do we find out about research that's happening in the CCM space?
Well, it just so happens there's this incredible alliance called the Alliance to Cure Cavernous Malformations. And I'm being a little funny, but there are designated centers of excellence, and there are different levels of expertise. So there's a clinical center and there's a center of excellence. Centers of excellence are places that specifically have research programs. So to this website for the cavernous, the CCM, the Alliance, you can look for centers of excellence, and they will tell you, which ones exist, where they are, and what some of the research foci are. You can also look online, and many hospitals have that, but that's a great centralized way that this organization has really been good about characterizing research efforts and what's going on, and certainly keeping a digital eye or digital ear to the intranet for this group is a great way to learn about it.
Thanks,
Katie,
thanks,
Katie
Dr.
knows the
Smith.
scoop. Yeah.
I do. Everyone feel free to email me anytime. I'll put my email in the chat too. Thank you so much for this incredible webinar. Everybody's just so appreciative. They say you should be a professional speaker, if you get tired of
Neurosurgery,
neurosurgery.
really. They please don't do neurosurgery. Don't come to the hospital. Just stay away. So you wouldn't be the first.
But we're
Well,
so thrilled to have you. Thank you so much. And the recording will be available soon. And then support group is where we're going next. So
well,
thank you so much.
I appreciate it. I really want to thank all the patients and families who have been so generous with their time, their effort. It's very humbling to work with with the incredible groups that are so engaged. So to all you out there who are family members and affected patients, we couldn't do this without you, as I've said multiple times. So thank you, and thank you to the Alliance. They're amazing. So they make the job easy. Have a great night, everybody.
Thanks. Good night, everybody. Take care.